Okay, so this is an exciting session here. It's meeting in the middle, bidirectional lessons for SUDEP from basic and clinical research today. We have two co-moderators of the session. I'm going to introduce Dr. Gordon Buchanan, who will then introduce Franck, who you've met already in the video. But Dr. Buchanan is Associate Professor of Neurology at the University of Iowa Carver College of Medicine. You can read his bio. I'm not going to do this. All the bios are in here. But I just want to say that Gordon has been a true hero in this space, and he has been at this work for a very long time, and he's been a lovely partner with families, and I'm just honored for his participation ongoing in this effort. So I'm going to turn it over to you and have you read the more technical bio yourself. Thank you all.
All right, thank you, Gardner, for that very kind introduction. Welcome, everybody. So I have the honor of introducing the basic science session, and I'll just say up front for the families, so I'm a physician also, and I understand, speaking to my patients, that the science can be pretty heavy, and I think that all the speakers will try to make it accessible to everyone. But if we fall a little short, feel free, especially for the families and patients, feel free to ask clarifying questions in our panel discussion. We're happy to clarify things more. So we put together this session. We're going to try to talk about what we learned from the clinics and how we can use that to try to understand biomarkers in our basic science work, and then how maybe we can take our basic science work back to the patients to try to understand how to identify people that are at risk for SUDEP and how SUDEP happens. As Gardner mentioned, Franck Kalume, who's associate professor at Seattle Children's, is co-moderating with me. He'll moderate more of the panel discussion at the end. So we have three speakers today. First will be Isamu Aiba, who's assistant professor at Baylor College of Medicine. Then we'll hear from Mark Stewart, who's the Dean of Graduate Studies at SUNY Health Sciences in Brooklyn. And then our third speaker, unfortunately, is ill and cannot be here personally with us today, but he's going to speak virtually. So we'll have a little hybrid session sort of towards the end. Okay, so first to introduce Dr. Aiba. Again, you have his full bio there in front of you, but he's assistant professor at the Baylor College of Medicine. He's, for a long time, has been doing postdoc studies with Jeff Nobles there, and now is starting his own research program, which we're very excited about there. And he's going to talk to us about some of his work looking at spreading depolarization following seizures and how that might relate to SUDEP, and tell us a little bit about some circuit mechanisms. Okay, so thank you, Isamu.
Good morning. I'm Isamu Aiba. Can I? I think so. Ooh. Okay, so today I'm going to talk about an event called spreading depolarization and its potential role in SUDEP. Sorry. Okay. So spreading depolarization, or just SD, is a slowly propagating wave of cellular depolarization. And can you play movie on left side? So on left side, this is right side, but SD is detected as a spreading wave of, like you can see, it's a spreading wave of white band. So this is an example shown in isolated brain tissue from mouse, and it evoked by KCL. So this is an example of SD, and SDs are massive depolarization of cells. So this is not just depolarization, it's really continuous sustained depolarization, as you can see on the under the movie. So you can see like 1 minute lasting depolarization, and membrane potential can reach up to 0 millivolt. And this is associated with a field potential change. This is also massive. It can create like 10 millivolt voltage changes and lasting for minutes. And also SD can be evoked in vivo on right side model. So this is evoking SD by KCL again in mouse cortex, in this case in anesthetized mouse in vivo. So again, ST is detected as a white band, you can see, and this is actually associated with, This is associated with slow potential shift and also a decrease in spontaneous activities. So because this is really massive depolarization, it can exhaust energy of brain and it can suppress activity of brain activity. So seizure and ST are technically excitatory events, but they are quite distinct mechanisms and also have different consequences. So seizure can arise as a recurrent excitation of group of neurons, and they can create synchronous activities and create synchronous action potential, spiking, and also burst activities, and result in generation of fast EEG signals. And seizure is also spread via neuronal circuit, so this is quite a fast evolving event. It can reach up to like 10 to 20 millimeters per second. In contrast, ST is a really depolarization of tissue, so volume of tissue involving neuron and also astrocytes. So ST can be commonly triggered by metabolic stress or massive circuit hyperexcitation. This results in depolarization of all cells in the brain tissue, including neurons and also astrocytes. So there's no homeostasis mechanism acting during ST, so resulting in accumulation of potassium and also glutamate concentration in extracellular space. And there's very limited clearance mechanism because all cells are depolarized and leading to sustained membrane depolarization. And because of ion concentration change during depolarization, it can associate with tissue swelling. So that's why we could see ST by optical signals. In contrast to seizure, which involve abnormal brain activity due to abnormal action potential firing, ST is characterized as a depolarization block. This is really sustained continuous depolarization above a threshold, leading to transient loss of brain activity. And spreading mechanism of ST is also distinct from seizure. Seizure is generally spread via neuronal circuit, but ST is more by a volume transmission. So during depolarization, there's increase in potassium and glutamate concentration. This can slowly diffuse surrounding tissue and then depolarize surrounding tissue, so creating feed-forward depolarizing wave. So this is usually 2 to 9 millimeters per minute. This is more than 100 times slower than seizure. So ST is quite extraordinary and really profound depolarization, but recent clinical studies showed that this can happen in human cortex. So one example is migraine with aura. So in migraine with aura, some cases, this is triggered by spreading depolarization in visual cortex. And this leads to a transient silencing of visual function and creating a wave of blind spot spreading through visual field. And also on right side movie, there's ST is also involving blood flow changes. And in this case, showing, can you play movie? So in this movie, ST is evoked in mouse cortex, and it triggers a massive blood flow increase. And blood flow increase during ST, especially in, you can see, so it's very fast, but you could see a red band spreading through movie. And this is a hyperperfusion in cortex. And this massive vascular dilation, especially in meninges, blood vessel is linked to headache pain sensation. And now ST is more extensively studied in the context of brain injury, such as subarachnoid hemorrhage, stroke, and also brain trauma. And this is an example of patient following subarachnoid hemorrhage and continuously recording brain activities. And 4 days after subarachnoid hemorrhage, in this patient, there are 4 STs detected as a cluster, and this ST was associated with confusion and sometimes loss of consciousness in this patient. So ST is really extraordinary event, but clinical study proved it is happening in human brain and contribute to some neurological deficits. And ST can also happen as a consequence of seizure, at least in animal models. So this is a recording of mouse, awake mouse. This is Dravet syndrome mouse model. So you can see seizure happening in the mouse inside the blue square. And in this case, this is a post-ictal state. This mouse experienced SD in this movie. So you can see slow trace drift. This is actually SD happening in this mouse, happening in fourth trace, now detected in second trace. So this is actually right hemisphere, first detected in posterior electrode, and now detected in anterior electrode. So this is an example of SD happening as following seizures. So we don't have strong clinical evidence, but there is some correlation with post-ictal deficit with this SD incidence following seizure in animal models, at least. Okay, I was talking about SD in cortex, but there are some studies have shown that SD can also happen in subcortical structures. In this case, it can associate with autonomic dysfunctions. So this is an example of SD recorded in anesthetized mouse carrying a mutation found in migraine in calcium channels. So this mutation can facilitate SD propagation. So when they trigger SD in cortex in this mouse, SD was also detected in striatum, hippocampus, and also in thalamus. And when SD was detected in thalamus, there was an increase in blood pressure. So this is hypertension. So it's quite rare to detect when we study only cortex. So when SD is happening in subcortical structure, there are structure-specific autonomic dysfunctions. And now moving to brainstem. So our group has been studying brainstem abnormality in SUDEP, and we have previously shown that SD may happen in brainstem during seizure-induced death. So this is an example of anesthetized mouse triggering seizure by applying convalescent on the cortex while recording in EEG activity and also electrical signal in brainstem. And you can see on left columns, after 3 seizures evoked by convalescent, this mouse suddenly died. But when we look at brainstem DC potential or field potential, there's a DC potential shift suggestive of SD, spreading depolarization. And this SD was associated with onset of cardiac arrhythmias. And when we look closely with respiration, this was happening as immediately following respiratory arrest. So we concluded that during seizure-induced apnea, this creates metabolic stress and leading to massive depolarization in brainstem and contributing to death. And we also tested whether brainstem SD is sufficient to trigger cardiorespiratory dysfunction. So on the middle column, showing experiment evoking SD in brainstem by applying KCl directly into brainstem. So application of KCl into the brainstem in this experiment triggers slow DC potential shift or field potential shift. This is SD. And this onset was associated with sudden respiratory arrest, cardiac arrhythmia, and also cortical EEG activity silencing. So brainstem SD seems to be sufficient to trigger deleterious cardiorespiratory dysfunction and also cortical activity silencing. And right side column is showing a test of brainstem SD susceptibility using acutely isolated brain tissue. So this was a movie, but essentially what we did is isolating brainstem slice tissue and exposing slices to a hypoxic solution. And then we could trigger SD in brain tissue. And what we found was when we compare between wild type versus mutant mouse susceptible to SUDEP, SUDEP mutant mouse showed shorter latency to this depolarizing event, suggesting that mutant mouse brainstem is more sensitive to hypoxic stress and can depolarize quickly. We also found that when we test the same experiment in adult mouse older than P60, SD was much more harder to trigger. So overall, this experiment is suggesting that gene mutation linked to SUDEP and also young age can significantly facilitate SD onset in isolated brain tissue. And so this finding was partly reproduced by other groups. So this is an experiment using anesthetized rats evoking seizure by canic acid in hippocampus. And this experiment, they have recorded EEG EEG, breathing, heart rate, and also brainstem activity, especially from pre-Betzinger complex. And this study essentially found similar finding. Following apnea, there's an initiation of SD or depolarization in brainstem. So top panel is showing a consequence of peripheral apnea. So after apnea, there's a depolarization in brainstem pre-Betzinger complex, and also cardiac arrhythmia leading to death. And lower experiment is also showing, this time is a central apnea. This is apnea was immediately followed by splenic depolarization in brainstem, and this was associated with very rapid, quick cardiac decline. So at least in seizure models, these seizure-induced death models, brainstem seems to undergo massive depolarization, and it seems to be happening as a consequence of hypoxic stress. But recent study from this calcium channel mutant model showed slightly different aspects of SD in brainstem. So left side experiment, this is experiment conducted in urine anesthetized mouse carrying this mutation. And this experiment actually imaged brain using MRI. So instead of inserting electrodes, they scan entire brain during the course of seizure-induced death. So seizure in this experiment, seizure was triggered by stimulating cortex, and they could trigger, in 17 experiments, they saw seizure-induced splenic depolarization in cortex. And out of 4 experiments, actually they found that cortical SD could spread into brainstem and leading to respiratory arrest. So in this experiment, they are claiming SD happened not as a consequence of respiration arrest, but as a SD is triggering respiratory arrest. And left side experiment is experiment in awake mouse, recording seizure and respiration, heart rate, and also brainstem field potentials. And this is complex figure, but essentially showing during spontaneous seizures, DC potential shift was detected in brainstem, ventrolateral medulla, and also pontine reticular nucleus. And SD onset in ventrolateral medulla was associated with sudden onset of respiratory arrest. So left side is irrecoverable brainstem SD. And this experiment, they also detected recoverable transient brainstem SD. So during seizure, there was a slow DC potential shift, suggestive SD, and this was associated with transient suppression respiration. So at least in these calcium channel mutant models, SD seems to be sufficient to trigger respiratory arrest. So this is a summary model of brainstem SD and potential association with SUDEP. So following cortical seizures, one possibility is this can lead to brainstem dysfunction, leading to apnea, bradycardia, and cause hypoxia and also hypotension. And this metabolic stress may directly cause brainstem SD or depolarization in brainstem, and leading to irrecoverable cardiorespiratory shutdown. And another possibility suggested from calcium channel mutant mouse model is seizure happening in cortex can transform into splenic depolarization in cortex, and this cortical SD may spread down into hindbrain and down into brainstem, and it can directly cause cardiorespiratory shutdowns. And there are some risk factors for brainstem depolarization. One is young age and also gene mutation, and there could be some other risk factors such as inflammation. And the question is if there is effective pharmacology to inhibit SD to prevent these potentially important SUDEP mechanisms. So SD has been well studied in animal studies for a long time. So there are several classes of drugs known to be effective to prevent SD. So one most popular drug is NMDA receptor antagonist. So clinically used drug is ketamines and also memantines. These NMDA receptor antagonists can prevent SD incidence in clinical studies, clinical settings in human patients. But these drugs need to be infused relatively higher dose, and because of side effect, it is probably not suitable for prophylaxis purpose. And SSRI, such as fluoxetine and also ketogenic diet, they are also known to increase SD threshold in animals. And animal studies have suggested that these treatments can inhibit seizure-induced death and also decrease SUDEP incidence in rodent models. So there's some correlation between SD inhibition and also seizure-induced death inhibition. And lastly, there's some SDs are actually sensitive to anti-migraine prophylaxis. And topiramate, propranolol, and lamotrigine, I didn't include here somehow. Chronic treatment with these anti-migraine drugs can actually increase SD threshold, and this drug can be also interesting possibility to test for its efficacy for seizure-induced death. And now I'd like to summarize my talk. So SD is a really massive and profound extraordinary depolarization, but clinical studies have shown that this can happen in human, at least in cortex. And when this happens in human cortex, this can lead to neurological deficits. And animal studies have shown that this SD can happen in subcortical structures, including thalamus and brainstem. In this case, this can lead to autonomic dysfunction and also cardiorespiratory dysfunction. And this brainstem SD has been shown to happen in multiple rodent SUDEP-related models. So this seems to be happening at least in animal models. And young age and some gene mutation have been shown to increase susceptibility to SD in brainstem. So this can be a risk factor for brainstem SD-induced death. So these are really basic study. So there's no clinical evidence, but high SD susceptibility may be a contributing mechanism for SUDEP. Thank you. Okay, is there any questions?
No, we'll do later.
Okay.
Yeah. Sorry. So we'll have a panel discussion at the end, and we'll take questions then. Thank you, Isamu. You did a really nice job, I think, of summarizing this really important phenomenon, giving us sort of the state of understanding from both the clinical and basic science side. So next we're going to hear from Mark Stewart, who's the dean in the School of Graduate Studies at SUNY Downstate in Brooklyn. And so his work, really focuses on the autonomic consequences of seizures, and I think he's a really good person to give us an overview of the state of our understanding of SUDEP biomarkers. All right, thanks, Mark.
So I can advance the slides here? Yeah. And then the movie, I signal them? I think so. Okay. Thank you very much, Gordon, Franck, and the organizers for asking me to talk about biomarkers in SUDEP. My intent is to make this as accessible as possible, but obviously, if it's not, I apologize for that, and we can talk about things after. So what are biomarkers, first of all? As this slide says, objective quantifiable features that we can measure that relate to biological processes, normal or pathological. And these can be chemical. The genetic code, for instance, is one example. Most of the results from a blood test are another example. They can be used to track the progress of a developing condition, the status of an individual. They can be anatomical or functional imaging features. As we've progressed with imaging technology from CAT scans through MRIs, through functional MRIs, our ability to see things in the brain and the rest of the body has increased progressively. Resolution has improved. The time scale for acquiring images has gotten better. The kinds of things we can see has improved. There are also electrophysiological features that we can detect, and that's where I'm going to focus today. I was asked to cover a couple of specific topics and also include some of our own work. So we'll talk about electrophysiological patterns as they relate to sudden death in epilepsy. Any of the biomarkers, chemical, imaging, electrophysiological, help to define risk. That's one of the reasons why we use them, especially in a condition where there's cumulative pathology. We can track the development of that pathology and then use that to define someone's increased or decreased risk. Importantly, they can help define mechanism. Biomarkers may actually signal features of a process and allow us to distinguish one mechanism or another if there are multiple ways to get from point A to point B. So for instance, from a seizure onset to death, if there are multiple paths between those 2 points, biomarkers may help to tell us which path was taken in a particular case. And obviously they can do both. So for instance, if you had an individual and you detected a particular path by which they went from a seizure onset into a near-miss circumstance, you might use that to stratify the risk of that individual. So the 4 biomarkers that I'm going to talk about today are heart rate variability, which is one of the best-known electrophysiological biomarkers. It's been used for a long time to talk about individuals' increased or decreased risk of sudden death, for instance, mostly sudden cardiac death. We'll talk about post-ictal EEG suppression, an important phenomenon that occurs following a seizure activity and relates to the seizure's impact on the rest of the brain. We'll talk about something near and dear to my heart, which is evidence of airway obstruction. And lastly, I won't talk about the mechanism of brainstem depolarization because you heard that from Dr. Aiba, but I'll talk about reasons why we think this might be actually turned into a biomarker that may have more widespread application. So to start with heart rate variability, what you see on this slide in red is an EKG. And what you see are red spikes. Each of those is an event in the heart. And if you measure the interval between successive heartbeats and plot those intervals as a function of time, you get the blue curve that's above. And what you see even from this short amount of time that's displayed is the interval varies. Oops, I went backwards, I'm sorry. So if you look at a stretch of heart rate variability for a longer period of time, that's the top trace here, you see that it's fairly complex. You can resolve that complex record of variance in the heartbeats in different frequency bands, and that's shown below. But the important point is that people have used these different frequency bands to infer features of autonomic function. The high frequency component, which actually is close to the respiratory rate, so about 1/5 the rate of the heartbeat, is often used to infer things about the parasympathetic part of the autonomic nervous system. The low frequency band is used to infer the status of the sympathetic nervous system. The bottom line is that lower heart rate variability is bad. And what you see in this slide from a recent paper from October of this year is one example where the investigators show that lower heart rate variability is more likely to be associated with sudden death. Post-ictal EEG suppression is illustrated in this slide, and what you see are 3 panels, the top and then left and right on the bottom, as a seizure starts and ends. And the red arrow in the bottom right corner shows this period of inactivity in the brain recordings. And this can be quite profound and last for a long time. And what was shown is that the duration of this period of EEG suppression also relates to sudden death. Longer periods of EEG suppression were more common in patients that suffered SUDEP. And one of the things that we were able to do in our animal work is something that has not so far been able to be done in people, and that is stick a laryngoscope in the mouth of an animal that's having seizure activity for the entire time that it's having a seizure. Normally, the airway opens and closes very regularly to accommodate breathing, but what you'll see here, and if I can ask you to play the video, is abnormal activity. You see a bit of that. It's only 30 seconds. But what you see after the abnormal activity is an active closure of the airway to produce complete obstructive apnea. One of the things we've done in this case is to actually look at what's happening during these periods of airway occlusion. What you see in this slide at the top is one channel of EEG recording. There's seizure activity on that channel if you look to the left. At the bottom is an EKG record, and in the middle is the record that comes from a pressure transducer on the trachea. And what we can see in that record are downward spikes. Each of those spikes is a great negative pressure that's being developed as the animal attempts to breathe during the period of airway closure. These forces can be on the order of 100 times larger than what the forces generally are in association with normal breathing. The arrow here shows that we can precisely define the point of respiratory arrest, that point at which the animal stops trying to take a breath. What you can see in terms of a biomarker here is that if you look for the high-frequency features of either the EEG or the EKG, and the filtered records are shown either up or down from the relevant traces, you see bursts of activity associated with each of these attempts to draw a breath. Those bursts reflect the intense thoracic EMG activity associated with each attempt to draw breath. This slide is supplemental data from an important paper that was published in 2013 summarizing the results of the Moderators trial. And one of the things that was a feature of that paper was that sudden death cases that occurred in epilepsy units around the world were curated by a panel, and these cases were used to define a sort of standard sequence of events from seizure onset to death. These examples come from those highlighted cases, and what you see here marked with red asterisks are EMG bursts. Now, the authors talked about these EMG bursts as actually being breaths by individual patients. We would reinterpret that data to say they're actually breath attempts made against a closed airway. A similar kind of phenomenon was detected and reported in other papers. This is one example from Samden-Latou's group, and what you see in the bottom are the inductance bands used to evaluate breathing, abdominal and thoracic bands, and you can see that the EMG activity increases as the effort on those inductance recordings increases. A second airway obstruction biomarker actually can be extracted and relates to heart rate variability. What's shown in black in the top panel is a variable heart rate, and the thick black bar at the bottom of that graph shows the period where the airway's occluded. And what you see to the left of the black is relatively small amount of heart rate variability, and then you see very pronounced variation in the heart rate. The large increases in intervals is a result of parasympathetic mediated missed beats. So the intense activation of the parasympathetic division of the autonomic nervous system causes the heart to skip beats. So the intervals get to be double or in some cases triple. The other interesting feature that you see here are very short intervals. That's the downward peaks. And what you see is that those downward peaks occur at the time of the maximum intensity of the breath attempts. This is a second supplemental figure from the Moderators result showing exactly that kind of short interval appearing in the subjects that were part of that raw data set. Now, the last biomarker would be brainstem depolarization, and these are anatomical slides that have more detail than you need. But the point is that the brainstem areas that mediate respiratory control, autonomic function, and actually auditory processing for at least a good part of that pathway all overlap in the same place in the brainstem. That's in the red box there. So we use the auditory brainstem response, which is a common recording that people make to assess the pathways associated with hearing. It's an electrical signal you detect when you play a click in the ear. And so what's shown here in the top are 3 10-second bits of data showing the stability of the auditory brainstem response. It's a polyphasic, complicated event that all you need to see is that it has a certain feature set, and those feature sets stable for the 3 different 10-second averages. In the second row, which is a little bit grayed out, you see 3 10-second chunks, but these are counted back in time from the point of respiratory arrest. So these are the last 30 seconds up to the point of respiratory arrest, and the brainstem response is still there. It's actually slightly decreased as you approach respiratory arrest, but it's largely still there. And then the 2 bottom traces or rows contain 10-second chunks reflecting the 60 seconds after the point of respiratory arrest, and you can see the auditory brainstem response failing, indicating a failure of the brainstem's ability to conduct these signals from the ear through to the thalamus. That failure curve is a very stable curve that's shown here in a blue line that's drawn over the blue bars. Those blue bars are the result of animals that have nothing happening to them except airway closure. And so the recordings are quite clean. In orange are animals experiencing seizures in addition to the airway closure. And so there's a bit more variance there because the seizure signal itself can interfere with the recordings of the brainstem. I'm getting to the brainstem depolarization here. So these are 4 sets of experiments, and you don't need to fuss much about the details except to see those large negative transients on the 3rd channel in each of those 4 panels. And with that, we can precisely define the point of respiratory arrest in each case. What's also true is we can see the point of brainstem depolarization onset in our recording channel that's meant to pick up the ABR. And so that's the channel that's actually the 4th one, second from the bottom in each case. The onset's marked here. What you can see from this slide and the lower left slide, actually the time base is twice as long, twice as much time, is that the time between respiratory arrest and brainstem depolarization onset is actually quite variable. So unlike the ABR failure, which if you imagine reflects brainstem failure, brainstem depolarization onset is more variable. So it's shown below the plot that you saw previously about ABR failure is the time of occurrence of the brainstem depolarization in these 10-second bins. Blue for the animals that did not have seizure activity, and orange for the smaller number of animals that did. The blue bar to the far left actually shows that the brainstem depolarization in some cases can occur before the point of respiratory arrest, but in most cases after, and in some cases quite long after. That bar to the right is 60 seconds or more. So the bottom line for this part of the talk is that biomarkers of the underlying events can reflect the mechanism to some degree and help identify deaths and near misses. It's our view that biomarkers of airway obstruction are a very important feature to look for. And if you look at the Mortimus result as being a sort of standard set of events, we would argue that it actually reflects our mechanism of airway obstruction as the underlying mechanism. And so we would argue that it's important to be looking for these biomarkers of airway obstruction. Now, the last point to make is that these biomarkers, in particular heart rate variability, can be used to assess overall cardiac and autonomic health. And while they originated as a method to assess somebody's declining health and stress that an individual is at higher risk, for instance, of sudden cardiac death, there is now a movement to actually use them as an assessment of fitness training to evaluate somebody's improvement in their cardiac and autonomic health. Now, whether that improvement is actually going to reduce the risk of sudden death in epilepsy or not remains to be seen, but it's certainly a trend now where there are many trainers actually take routine EKGs and assess heart rate variability. So with that, I'll say thank you very much, and I look forward to our discussion.
All right, thanks, Mark. That was really a great overview of the biomarkers. So our third speaker is Dr. Detlev Boison. I don't know what this is, but put it back. Okay. And he's he's professor and vice chair in the Department of Neurosurgery at Rutgers Robert Wood Johnson Medical School. He's really had a long-standing research interest in translational adenosine work and is interested in metabolism-based therapies. So Detlev is going to talk to us about neurotransmitters as in relevance to SUDEP. So Detlev, welcome. Thank you.
Good morning, everyone, and thank you very much for the kind introduction and invitation. Unfortunately, I got sick this week, and that prevented me to attend in person. Today, I will talk about the role of neuromodulators in SUDEP. So this doesn't work. Okay, those are my disclosures. Learning to appreciate the importance of basic research findings in our understanding of SUDEP, to identify at least 4 neuromodulators implicated in the pathophysiology of SUDEP, and to appreciate opportunities for clinical intervention. So SUDEP begins with risk factors, which include poorly controlled generalized tonic-clonic seizures, and it ends with the final seizure followed by fatal respiratory arrest. In between are complex interactions between central autonomic networks and respiratory control centers in the brainstem. And neuromodulators play an important role in mediating those interactions, and those include orexin, norepinephrine, serotonin, and adenosine, and I will talk about all 4 of them today. So let's talk first about the orexin hypothesis of SUDEP. So central to our understanding about the mechanisms how breathing can be controlled is an autoregulatory cycle that is able to chemosense CO2 levels in the blood and pH fluctuations in the blood. So that basically means if there's a period of apnea, we get an increase in blood CO2, hypercapnia, which then triggers hyperventilation. Hyperventilation in turn reduces CO2 levels, which then can cause apnea. So this regulatory cycle appears to be disrupted in SUDEP, and serotonin plays a key role in promoting recovery. However, serotonin is also under the control of orexin, which is a neuropeptide produced in the hypothalamus and which regulates serotonergic neurons in the Raffin nuclei and in the locus coeruleus. So the diagram on the right shows that we have normal breathing followed by apnea, and then it triggers hyperventilation, and finally final bursts of breathing followed by lethal apnea, and the autoregulatory mechanisms fail in this paradigm. So the orexin system offers therapeutic opportunities. So this has been intensively studied in the laboratory from the Simeonis. They used mutant mouse model with KV1.1 mutations, which creates a progressive SUDEP risk, which means that each age has a defined SUDEP risk. And what they found is that SUDEP risk is associated with higher levels of orexin. And in line with those findings, they found that a dual orexin receptor antagonist called DORA ameliorates apnea and extends the life expectancy of those mutants. Next slide, please. Yeah. So the next neuromodulator that is important in the control of breathing is norepinephrine. So norepinephrine plays a central role in breathing regulation. And this is a study that used a mouse model of acute intermittent hypoxia, which alone causes only mild breathing irregularities. But then they injected norepinephrine into the pre-Bötzinger complex of those mice, and norepinephrine acutely increases breathing as expected. But when followed by acute intermittent hypoxia, there was a profound triggering of increased breathing irregularities. And they could also replicate those findings by using norepinephrine reuptake inhibitors, which also, when followed by acute intermittent hypoxia, could trigger irregularities in breathing and also death. So that means that the norepinephrine system plays a major role in controlling those autoregulatory mechanisms implicated in breathing. So there's therapeutic opportunities on the side of norepinephrine. Next slide, please. Okay. Oh, sorry. So this is work from Gordon Buchanan's lab. So they used a mouse model where sudden seizure-induced respiratory arrest was induced by maximal electroshock. And they found that norepinephrine reuptake inhibitors could prevent seizure-induced respiratory arrest. And this effect was mediated by alpha-1 receptors and could be blocked by blocking alpha-1 receptors. But there's also an interaction with the serotonin system. So they used a model where they depleted noradrenergic neurons in the locus coeruleus. And in this case, serotonin reuptake inhibitor was no longer able to prevent seizure-induced respiratory arrest. And this finding brings us to the serotonin hypothesis of SUDEP, which has a lot of scientific basis. First of all, by patients who suffer from breathing disorders, it was found that a serotonin-enhancing drug was able to restore normal breathing patterns. And serotonin is, regulates breathing through the serotonin axis. So two separate types of serotonergic neurons control the activity of motor neurons in the phrenic nerve, which trigger the breathing rhythm. And the whole system is linked to chemosensation of fluctuations in carbon dioxide and in pH in the blood, which are sensed by midbrain serotonergic neurons, which controls thalamocortical circuitry and arousal state. But it's also sensed by medullary serotonergic neurons, which control ventilation through respiratory nuclei in the brainstem and thereby recalibrate CO2 and pH. So therapeutic opportunities for the serotonin system have been explored on several different levels. It was shown that serotonin reuptake inhibitors have tremendous therapeutic potential. In one study, fenfluramine reduced seizure-induced respiratory arrest in DBA1 mice. Fluoxetine reduced seizure-induced respiratory arrest in DBA2 mice. The SSRI citalopram increased survival after maximal electroshock seizures in mice which have intact serotonergic neurons. But this strategy no longer worked in mice that lacked serotonergic neurons or in mice that lacked norepinephrine neurons. And also clinically, it was found that adjunctive treatment with fenfluramine reduced the frequency of convulsive seizures in patients with Dravet syndrome. So it is also important to note that medullary raphe serotonergic neurons are characterized by decreased firing during and after seizures. So this raises the interesting question, what causes the suppression of the firing of those serotonergic neurons? And this brings us to the next topic, which is adenosine. And the adenosine hypothesis of SUDEP is based on the following. So for over 30 years, it has been known that seizures trigger an acute surge in adenosine, and it's the seizure-induced adenosine that normally acts as the terminator for seizures. So that's an endogenous control mechanisms by which seizures normally self-terminate themselves. But adenosine in the brainstem can also suppress respiration, which has been shown by the injection of an adenosine analog into the nucleus structus solitarius, which suppressed respiration in adult rats. So that means if adenosine can trigger SUDEP in the brainstem, there are therapeutic opportunities for caffeine, which is an adenosine receptor antagonist. And I want to switch gears slightly towards traumatic brain injury, because one of the major causes for acute death after severe traumatic brain injury is lethal apnea. So an early study from Pat Kohenek at the University of Pittsburgh has shown a correlation between high levels of CSF adenosine and lethal outcome after human traumatic brain injury. And we replicated this in a rat model of fluid percussion injury to induce severe traumatic brain injury. And in this model, we had a mortality rate of 46.7%. So all those animals that died from lethal apnea. So we then had basically those dying rats. And as soon as apnea started, we gave a single injection of caffeine. And the caffeine rescued all of these animals. So none of the caffeine-injected animals died from lethal apnea. So we also studied the therapeutic benefit of caffeine in a mouse model where we induced SUDEP-like conditions by combining drugs which block the metabolism of adenosine with a systemic injection of canic acid to trigger status epilepticus. And with this combination, we were able to create lethal outcome with all of our animals that received this double treatment dying. When we injected these animals with caffeine, we could extend the life expectancy of the animals. Okay. So interestingly, there is a crosstalk between the adenosine and serotonin system. So we've learned that serotonin has beneficial effects on the respiratory network. Adenosine However, through activation of adenosine receptors can inhibit the respiratory network, but there's also a direct interaction with serotonergic neurons because the presynaptic adenosine A1 receptor provides presynaptic inhibition. It basically prevents the release of neurotransmitters from the presynaptic terminal, and this also affects the presynaptic release of serotonin. So this mechanism, adenosine is able to prevent serotonergic neurons to release adenosine. And in the big picture, we have seizure spread to the medulla, which then has a direct effect on descending arousal system, including serotonergic neurons, but also increased extracellular adenosine. And both dysfunctions together affect respiratory nuclear dysfunction inhibition, which leads to apnea, but also contribute to autonomic factors that cause arrhythmias and finally SUDEP. So we studied the adenosine system as a way to identify, can we predict SUDEP? Can we predict SUDEP, and can we prevent SUDEP after prediction of epilepsy? So in this study, we used a rat model. So we first pre-treated the animals with an injection of 5-iodotubercidin, which is an adenosine kinase inhibitor, to block the endogenous metabolism of adenosine. And 15 minutes later, we gave an injection of canic acid to trigger the status epilepticus. And with this treatment, we could trigger SUDEP in our animals. So what we did in those recordings, we measured heart rate, blood pressure, EEGs by EEG recordings, and we directly recorded from the phrenic nerve, which controls breathing. And what you can see in these images is that an event that always preceded SUDEP were irregularities in phrenic nerve activity. So this was the first signature that we could identify as a predictor for imminent SUDEP. So in this model, it's interesting to note that the pre-treatment with ITU also led to a delay of the status epilepticus, which makes sense because adenosine has seizure suppressive roles, but nevertheless, this combination was able to trigger SUDEP in those animals. So this is basically a summary slide which shows profound reduction of phrenic nerve activity in the animals pre-treated with the adenosine kinase inhibitors ITU, which is the red line on the bar graph on the left. And we also looked at phrenic nerve activity irregularities, which became evident 60 minutes after giving ITU to those animals. So those phrenic nerve irregularities are a biomarker for imminent SUDEP. And in line with that, we were able to prevent those irregularities with an injection of caffeine. So that means we can possibly use the detection of phrenic nerve activity as a system to predict SUDEP and to couple this detection with an intervention. In order to look at this, let's have a look at diaphragmatic pacing. So this is a surgical intervention used in patients to promote breathing for example, after spinal cord injuries, when endogenous respiration is no longer possible. So we did a proof of concept study where we induced diaphragmatic pacing in anesthetized mice. And as this graph shows, so as soon as we stimulate the diaphragm electrically, we can increase breathing. So that means, can we prevent seizure-induced respiratory arrest with diaphragmatic pacing? So we used a mouse model of maximal electroshock induced SUDEP. So on the top graphs, you can see a fatal seizure without the diaphragmatic pacing. So you can see that following the seizure, there is respiratory arrest and final death of the animal. In the bottom part, we had these animals and waited until they went into respiratory arrest. And then we induced diaphragmatic pacing for 20 seconds. And as this graph shows, 20 seconds of diaphragmatic pacing was able to restore breathing. And none of the animals that received diaphragmatic pacing died. So can diaphragmatic pacing be used as a countermeasure against SUDEP? Possibly yes, because several persons with epilepsy have vagus nerve stimulators, and sometimes there's accidental stimulation of the diaphragm, which can have an impact on breathing. So based on the implantation strategies, it could theoretically be possible to combine vagal nerve stimulators with an additional set of electrodes to stimulate the phrenic nerve. So let's summarize the therapeutic opportunities surrounding neuromodulators. So today I talked about adenosine, serotonin, orexin, and norepinephrine. So serotonin can prevent SUDEP through the chemosensitive system, and serotonin itself is regulated by norepinephrine and orexin, and also by adenosine. And adenosine, in addition, can promote SUDEP in the brainstem in a chemosensation independent way. And there are a variety of drugs available to interfere with those processes, which include norepinephrine reuptake inhibitors, serotonin reuptake inhibitors, dual orexin receptor antagonists, and caffeine. So what are the challenges for therapeutic implementation of those strategies? So first of all, we need to identify a suitable target population who should be treated. So ideally, everyone is poorly controlled generalized tonic-clonic seizures. But the treatment needs to be without major adverse effects. And ideally, it would be good to have biomarkers to predict those who would benefit both. Patients with implanted neurostimulation devices might be good candidates for diaphragmatic pacing or phrenic nerve stimulation. When should treatment be initiated? Ideally, as early as possible. closed-loop feedback system that can predict imminent SUDEP risk might provide an opportunity for precisely timed therapeutic interventions. Okay, finally, I wish to thank all of you for your attention. I wish to thank my fabulous research team. We are actually standing in front of a sculpture of caffeine, which motivated me to move to Rutgers. I wish to thank our collaborators and our funding organizations. Thank you very much again, and I welcome any questions in the Q&A afterwards. Thank you.
Great. Well, thank you, Detlev. That was a really great overview of the neurotransmitters. I have to say, as somebody who's been to every PAME session, I'm really struck how far we've come in our understanding of all of these mechanisms. I also appreciate that we still have, quite a ways to go, but it's really amazing to see how far we've come. I'd like now to introduce or invite Franck Kalume from Seattle Children's to moderate our Q&A session. It's up to you.
All right. I think the mic is on. Hi, everyone, and welcome to the PAME plenary on the basic science. And it's a great pleasure to have every one of you here and to share the science together. And as my colleague and friend Gordon just mentioned, it's such astonishing to see where we've come in these 15 years of SUDEP research. And it's just amazing where we are. We still have a long way to go, and let's see how to move from this point on forward, and some of the things that can help us look on the way ahead are the questions that are coming through these after these kind of talks. And then I will invite people to get to the microphone. There should be some microphone in the back of the room, and here for George. Yeah, somebody's coming in the back. And so we'll have George and somebody, a second one coming over there. Okay.
So this question is for Dr. Aiba. So I always wondered whether or not the brainstem spreading depression was the cause or an effect of breathing, of apnea. And you showed nicely today that it looks like it's probably because of the apnea. And that makes me think about an observation that we've made that we have not really followed up on or been able to characterize well. And I was wondering if you could address this with any of your experiments. And that is that in a lot of mice, so when we study mice and we induce respiratory arrest from seizures, a lot of times we can just put them on a ventilator and they come back and they recover well, and then we can do it again. But in other cases, especially if we wait too long, like a minute, which in a mouse is an eternity to not breathe, we can't, no matter what we do, we can't get them to come back. And I've always wondered if that was a result of brainstem spreading depolarization occurring, and at that point, the horse is out of the barn. It's just no way to get it back because of all the depolarization and activation of neurons. Have you done any experiments or seen anything in your experiments that would help explain if that could be what's going on?
That was for Isamu, right?
Yeah.
That's for some, yeah.
So he's asking.
Microphone. Oh, sorry.
I'm just explaining to him.
Okay.
It's kind of, yeah.
Right.
He's in some mice die right away with in the respiratory rest, and you can put them on a ventilator and recover. But some, it takes a really long time. And he's wondering if you could get at any of that with your experiments.
So it depends on, I think, available metabolic supply, especially cardiac functions and also respiratory functions, and also neural damage resulting from depolarization. So some mass, so we are only talking about SD susceptibilities, but some case susceptibility can also affect consequence of SD or depolarization. So some case neuron become more vulnerable to depolarization and die very quickly. But in some cases, neuron can depolarize, but they can still recover or repolarize. So we are just focusing on, for now, talking about susceptibility of SD, but I think it's important to understand the consequence of depolarization to understand more time window after respiratory arrest-induced depolarization. So if we can maintain, so even if we can't prevent SD, we may be able to facilitate repolarization of these neurons. In that case, maybe pulmonary support can reverse death, I mean, not reverse death, but resuscitate the animals at least.
Thank you. Thank you.
So it sounds like there is, I wanted to add a comment here, maybe to elaborate on your question, which is where do we intervene? Do we want to intervene centrally or peripherally? And what's the advantage of each one of those approaches? Is there one place that is more advantageous than the other? And that can apply to all the speakers, I will imagine. Yes.
So from our perspective, in terms of intervention, what we've seen is that we can delay the time to respiratory arrest with SSRIs, with oxygen. In the case of a phenomenon like asystole, so where the heart stops beating during a seizure, the seizure can't be supported any longer. The seizure stops, the stimulus for the asystole goes away, and the individual recovers from that asystole. In the case of our obstructive apnea mechanism, if you reach the point of respiratory arrest, usually you don't spontaneously recover. And so there's a temporal competition between how long the apnea lasts as a result of the seizure and when you reach respiratory arrest. So if you can delay that, you run a higher chance that the seizure will end naturally and there'll be no trouble. Otherwise, you need something such as the diaphragmatic pacemaker or CPR after the point of respiratory arrest. But there are interventions that you've seen tested, at least in animal models, that make some sense prior to getting into serious trouble.
You know, that I think depends a little bit on the model. So in our SCN1A mice, sometimes when they have respiratory arrest, there's just no point, there's no recovering. Whereas in the SCN8A mice, it's really uncommon. They have a lot of seizures that lead to transient respiratory arrest. So, and it's in those two cases, it's both due to central apnea. And so it may depend on the model, and rats for us are very different than mice. So one of the advantages of this type of session is discussion, so that's nice. Thank you for adding that.
All right. Thank you. And we'll take a second question here.
Thank you. My name is Lee Goldie. Dr. Stewart, I had a question for you. I appreciated what you stated about the biomarkers, the 3 types of biomarkers you listed. The last one that you stated is biomarkers assess overall cardiac and autonomic health. I'm an epilepsy survivor. When I had epilepsy, I was also not related, in my opinion, or I was told, diagnosed with a heart murmur. I've been seizure-free because I had brain surgery. So recently I was tested and my heart murmur is gone because I'm off medication. I don't know if there's anything related to being off medication or not. I now run a nonprofit for people with epilepsy in Cleveland, Ohio. Many people that I talk to are also experiencing heart issues. How often do epileptologists and neurologists collaborate with cardiologists to determine if this is a biomarker that could be addressed before SUDEP?
So I can't speak for all the neurologists, but I know many who collaborate very intensely with cardiologists and other clinical specialists. We do. We've had a cardiology collaborator for a long time. Some of the phenomenology that we study in the animals relates to a natural phenomenon. When you obstruct the airway, the body's response to that is to protect the core blood flow, and your ability to do that speaks to how well you might survive an event like this. So we have a regular collaboration. What's nice about the animal models and a meeting like this, or our collaborators, is we can suggest something, or they can suggest something that we test in an animal and go back and forth between the bench and the bedside. That's the goal of the animal model, not to fix epilepsy in a rat or a mouse, but to explore things that are difficult to do in people. So the short answer is I don't know what the upside is, but I can't imagine a downside to that kind of cardiac and autonomic fitness.
Thank you very much. There is another question right here. Yes. And then next will be David.
Good morning. My question is, I lost my son to SUDEP 9/2 of 2019. And my question is that a lot of us as parents fight for devices. We want divisive help in our homes. My son with special needs, and I fought for years for divisive help that I never got. And the questions that I was faced with was why? Why would you not offer this type of help to kids or adults who are suffering at the hands of tonic-clonic seizures, which we know that they are very dangerous forms of seizures? Why is it that medical professionals have a hard time getting the insurance companies to help us to be able to rectify waking up the next morning to seeing your child in the bed deceased? This is an overwhelming discussion amongst many of families. We are not able to get this help. And in honor of our son, we started a nonprofit called When the Trumpet Sounds. Because what I'm finding out is that it's too many of us who have been quiet for far too long. It's now time for us to stand together and to strategize a plan to where the parents, caregivers, doctors, and insurance companies alike can work together for the good. Because we appreciate the medical professionals standing in the gap for us. But the reality of all of this is we endure 24/7, 365 days out the year. We get no break. And when we come and ask for the help, it's not help that we think that should be pushed off to the side because we are enduring. Is there something that we can do as parents and as caregivers of those who we take care of on a daily basis, that we can get medical professionals to stand up with us and to help us to take accountability for the loophole that is taking place so that we will no longer wake up the next morning and find our loved one or our children in the bed and taken on home to SUDEP?
Yeah, thank you so much for that really tough question to answer. And as researchers, we'll try to get some clinicians in the room who can help us navigate that question because it's touched onto multiple things involving insurance and providing care in different areas. Anyone want to try that? Gordon.
Yeah. I would say I think that this might be covered a bit in like the next session also. You know, I think some of the work that we're doing here will help inform some of this to help sort of give more fuel for the fire to decide like which devices might be best and what we'd really, you know, be intervening upon. There are a lot of, as a physician, there are a lot of challenges to get these things for people and to get them covered. so that's probably bigger than what we can cover right here. And Dr. Donner, I think, would like to comment.
Is it on? First, thank you for sharing your story, and thank you for being here at this meeting, because we need scientists to hear your story, clinicians. I'm a pediatric epilepsy specialist, and I can't speak to the insurance issue because I work in a different jurisdiction, and so I can't speak to that. I think it's really important, though, as we hear this science, that we also put it into context, because we are learning a lot about SUDEP, but we also know that there are people who die from SUDEP whose families are there with them, and people weren't actually able to do anything to save lives. So it's really important that as we hear about things that we might have done, that we also recognize that sometimes there wasn't anything that we could have done, and families need to also, I think, hold that. And I just wanted to make that comment. The other thing is I think we're making tremendous progress with devices, and we need the device companies, and this is happening now, and the people doing the research into the devices to collect data that will inform lobbying to the people that pay the bills, so that we can make that happen for you. And it's through meetings like this that I really do think that'll happen. So thank you. I hope that addresses it a little bit.
I just want to follow up on a comment earlier. It's tough to respond after such moving statements there, so thank you. But on your question about the heart component there, Dr. Stewart gave great presentation examples of we need to be looking at it in a bidirectional way. And yes, these seizures can be causing cardiac abnormalities. Cardiac abnormalities can be leading to cerebral hypoxia, leading to seizures. It may be the effects of medications. It may also be the genetic component. So it is so multidimensional that your question is right on point, where we don't have a lot of answers for this. That there's a large bidirectional relationship there.
Thank you very much, David. And there is a hand on the other side of the room.
Thank you. So I think the approach to insurers has to rely on an argument that shows necessity and effectiveness. And I think that the way you start to build that argument is to say we believe that this device, this intervention is necessary to prevent SUDEP, and that it is effective at preventing SUDEP. And so I was really excited about the slide that I think it was you, Dr. Stewart, who showed that in your animals treated with kainate to induce seizures and spreading depression, that respiratory response was lower sooner than with apnea alone. Was that your slide or someone else's? But what that said to me was there might be an added effect of seizures plus the respiratory suppression that would argue that the window for resuscitation is smaller in people with epilepsy. And so we need an immediate type of intervention in order to get out of that respiratory arrest. So I think I am seeing incredible progress in the last couple PAME meetings, as somebody has mentioned, that we're starting to build maybe a case where we can go to an insurer and say, we've got enough evidence to show that this can be prevented if you provide these kinds of supports.
Thank you very much. And there is in the back, Jeff has a comment in the back over there.
We always, you always wonder who you haven't invited to the table when you do a meeting or have a discussion. Early on, we forgot about medical examiners. That was a big mistake, and we invited them in. I think the point that you were making is that we need to involve the policymakers, healthcare policymakers. And the way that it happens is from the advocacy community. Two examples. The first, and some of you may remember HIV, AIDS, and the organization ACT UP. This was a patient family organization that said, we're not gonna wait for you to do your regular thing. This is important. You need to do things now, and they did. Recently, the FDA approved a medication with marginal evidence for Alzheimer's disease. Why did that happen? It happened because of advocacy organizations pushing hard to make sure that this was done. And I'm not going to comment on whether it should have been done, but I think what it does is it demonstrates the power of the community. And with regard to insurance kinds of issues, the folks in this room aren't going to solve it. As Brandy said, we'll provide data and evidence, but what really pushes it are people that are living the experience.
Thank you very much, and that's a very important comment there too. And another question right here.
Yes, I'm Isa. I'm a mother also in Renan Foundation, and I just wanted to point out two things, and that is in the seizure detection, what I'm hearing is the scariest part is the apnea, okay, which typically occurs during the tonic phase of the seizure. As parents, we typically detect seizures when they gasp, okay? And so we miss this really critical part. And it's the hardest of these seizure monitorings to detect. So what they normally are good at detecting is that movement. It's too late. Like they've already come out is what I'm hearing of the dangerous phase. So I just want to point that out, that this first step, I mean, how do I know when my daughter, and she's had numerous devices, I hear it because I hear a gasp, and I've missed the point of intervention. And also, a lot of our kids, this correlation with the autonomic system, there's lots of correlations. Our kids post-ictally, their temperatures fluctuate, their heart rates fluctuate. Is this, a predictor of her susceptibility? So there are a lot of autonomic signals that can be explored in our children, and hopefully, but we need an intervention that works, you know what I mean? So that when we know that they're at risk, we have some kind of tool to handle, to give to our parents to say, here you go. Here's something that you can do. So just comment. Thank you.
Yes, thank you for the comment, and then I'll let Dr. Stewart make another comment on this.
So related to that, what our experience is that once the point of respiratory arrest is reached, you're not out of the game. You just need help to get started again. And so what Dr. Boison's talk about a diaphragmatic stimulator did was it caused the breathing movements that were necessary. An alternative to that is CPR. And going back to the Mortimus paper, their experience was that everybody who was given CPR within a short time after what they called the onset of terminal apnea, which we would interpret as the beginning of respiratory arrest, they were recovering. So the key from my perspective is that if you're looking for this, you're ready to do that sort of thing. And there is a window within which you can bring someone back, fortunately.
Thank you. I would like to give a moment to Dr. Boison for any comments, because he's online and difficult to intervene easily.
Yeah, I think there, in regards to the first talk, I think there are a lot more interactions that would be worthwhile to explore. For example, I strongly believe that adenosine is also involved mechanistically in the phenomenon of spreading depolarization. And that's something that might also be worth of future exploration.
Yeah, I think I see the time here at 0.
Can I take one question?
Oh, we can still go. There is a question there. Okay.
I'm Melissa Barker-Holiski from the University of Washington. I'm a researcher, and I wanted to say thank you to having the parents come and give their story and testimony. That's always really helpful as a researcher. I wanted to ask to the panel really quickly, there is a known sexual dimorphism with SUDEP risk, and I was curious if there are any contributions that you're seeing with sex hormones or any additive effects of sex as a biological variable in your basic science research. Thank you.
Yeah, the question is there any biological effect of sex hormone?
So not in our work. We've looked at male and female animals and don't see a difference.
Yeah, also in our work, we didn't find any differences between males and females.
In some animal models, there are some sex differences in susceptibility to the seizure-related death, for instance, to maximal electroshock or to smaller doses of chemical stimulation. We've seen that in our mice that don't have the serotonin neurons. And there is some ongoing work. I think there may be a poster at AES about this from Katerina Sosa with Dr. Richardson's lab, who's very interested in the role of sex hormones in SUDEP, in Dravet. She's sitting up here if people want to ask her questions later.
All right, thank you. Any other question that we missed? Oh, yes, there's one here.
I can speak loudly.
Where's the microphone?
So in the Mortimer study that was published in 2013, they talked about CPR in their cases. I can't speak to the broader picture that Dr. Buckhalter was talking about. I made one reference to only that study.
Okay.
All right, well, wrap it up?
Yeah, wrap it up.
Yes, thank you. Thank you very much, everyone, and thank you for the discussion.
And I just want to thank the panel, and I forgot to mention this morning, but we have first time ever little speaker thank you gifts. It's a magnifying gift, and it says, "Thank you for magnifying the problem of epilepsy mortality." So thank you all so much. There's one on the table for each of you. Now we have a short break, and we'll be back at 10:45. Thank you.